This
Okay.
conference will now be recorded.
Good evening, one and all. I am Nusrat Fatima, your session coordinator for today. I am glad to announce that we have been together in this learning since the 10th of October 2020, successfully conducting sessions, and it's our 27th session today. Today, among us as a faculty, a supervisor, and chief guest, we have a successful teacher, a great mentor, and author of a textbook himself, Dr. Mudabbir sir from the Department of Forensic Medicine and Toxicology, Deccan College of Medical Sciences. Dr. Mudabbir sir is truly an inspiration who is well versed in not limiting a class motive to rote learning but to make it fun, easy, and informative for a student. Not only limiting himself to teaching, Sir has also penned down his extremely vast knowledge into a textbook for forensic medicine and toxicology, which is a very talk about book among second year MBBS students. Its easy, comprehensive, and exam friendly nature has made it #1 student's choice book. I thank Sir for sparing out his precious time from his stringent schedule to guide us ahead and to the best. Throwing some limelight on our initiative, which is indeed a small baby step in the field of teaching, upon pondering and realizing the importance of a senior guidance in making medicine an ought to subject rather than to be fought with, we have taken this voluntary initiative to establish an inter-college student teaching cum interaction organization, Medico Hub. By the successful participation shown by our first year colleagues, the participant roll has reached to about 500 members on our WhatsApp groups, which consist of first year MBBS students from about 20 colleges, not only from Telangana but also from Andhra Pradesh. With this initiative, we have tried to make medicine learning as simple and as interesting as possible and have turned out to be fruitful in our goal, which is evident from the great post session feedbacks which we are receiving. Introducing up the panelists, we have Syed Arbaz, who is our student president, Mohammad Sadat MOHIUDDIN, who is the student secretary, and myself, Nusrat Fatima, who is the chief advisor, and our board of directors consisting of Syed Zaki, Pranav, Dr. Sayyeda Ahmadunisa Samira, and Anant Nayak. We are all students of Deccan College of Medical Sciences 2017 batch, and Pranav from Bhaskar Medical College. Thank you, sir, for being with us. I would like to hear. I would like to request you to tell a few words before we start the session. Over to you, sir.
Okay. Thank you, Nusrat, for praising me. Alhamdulillah. Actually, you are my students are my inspiration. Actually, I love my students and I want to share my knowledge and my desires are my wishes. Best wishes are always with you. Alhamdulillah.
Thank you,
And
sir.
one more thing, the success of students, first of all, is appreciated by parents, then your teachers. Usually, your success is our success. So really, I felt happy to hear you that you have initiated this learning. Actually, we are facing some extraordinary conditions, actually, situation because of COVID pandemic. So because of that, you are unable to attend classes physically. So, but they should not hamper our studies, actually. So anyhow, the time will pass, exams will come, and you have to face the exams. So in this situation, survival of the fittest. We have studied this in previous classes, actually, during our schooling. So now this situation fits on our studies, survival of the fittest. So anyhow, we have to study. We have to inculcate the knowledge. We have to be par with other students also all over the world. So it's really very good initiative that you have brought up some platform so that students can join there and share their knowledge in a professional way. Alhamdulillah, it's very encouraging also.
Yes.
So otherwise,
Thank.
just sitting at home, you will lose your interest and you lose your knowledge. So it's very good. So anyhow, you have done a very good job, and more people. I hope more students will join, inshallah. Uh, and moreover,
Yes.
whatever the situation will be, our Indian doctors are doing very good in all over the world. They are in demand actually. So this COVID pandemic should not hamper this actually. So that we are very knowledgeable. Indian doctors are very knowledgeable, very practical, very humble. They are very patient friendly and all. So I wish all the best for all the participants, and especially the one who has organized this board of directorates, whatever it is. So I welcome now to the speaker.
Yes. Thank you, sir.
Thank
Thank you for your kind words. I
Yes,
hope with your blessings and participation, we will move this organization more ahead. Yes, Pranav.
yeah, am I audible?
Anyone audible? Yeah, you
Yeah,
are audible.
before we start, I just wanted to thank Mudabbir sir. Sir, I'm a second year medical student from Bhaskar Medical College. It was Arbaz who introduced me to your book, and your book, sir, is just fabulous. The concepts are clear, crisp, and they're presented in a very fantastic order, sir. And not just me, but many of my friends here follow and love your book. We can't appreciate it enough, sir. Thank you very much.
Thank you. Thank you very much. Thank you.
Yeah. Uh,
Yeah, thank you, sir, for being here, for sparing your time with us to encourage us and to encourage our attendees, also about what to be done and how a doctor should be. Thank you so much. We
Okay,
appreciate
thank
that.
you. Really, I'm very happy to get reconnected with you people. I was feeling
Yes, sir.
I was feeling good because usually I'm very friendly with students. I want to speak to the students. So
Yes,
it's a
sir.
good initiative you have done. Inshallah, it will be a grand success and it will improve your knowledge basically. Inshallah, your teaching
Yes, sir,
skills,
indeed.
your communication skills will also improve. Inshallah, that is very important nowadays. They are emphasizing on communication skills. So inshallah, you will develop this also. Inshallah, all the best.
Yes.
Now we can start with the topic.
Yes, sir. Thank you, sir, for being with us over here and for your blessings and being such a wonderful teacher and a mentor, sir. Thank you.
Thank you.
Over to you, Sadat. Please, yeah, move ahead with the topic. And whoever is having doubt, as usual, you can put it in the chat box and we'll convey it at the appropriate time. Okay? Sadat, you're not audible. Hello?
Sadat is still muted.
Yeah.
Yeah, sorry about that.
Now you're,
Let's begin our
yeah.
session now. Yeah, let's just discuss the basic keywords today: osmolarity, concentration, and dilution. Obviously, you have learned this in Inter. It's nothing new to you guys. So basically, when we see a cell, consider a cell which contains solute, that is solute in a solution of a cell, this is considered as osmolarity. Okay, this is considered as osmolarity. Nothing but the amount of solute present in a cell containing in a solution. Understood this? That is amount of sodium, for example. That's why I've drawn this diagram. Okay. Now I just want you guys to compare with the surrounding. Okay. Here we can see only one sodium, and here there are a lot of sodium ions present. So when I'm comparing with the outer side, we can see that this has more sodium. So what will I call this? I will call this cell as hyperosmolar. Do you understand this? Do you understand this? Yes, very simple. So this is considered as hyperosmolar. Okay. Now when I'm talking about hyperosmolarity in our body fluids, or in our blood, okay, in our blood, the normal osmolarity in our blood or in our body fluids is 300 osmoliters per liter. Okay, milliliters. Okay, 300 milliosmoliters. So you have to remember this value. Okay, everything will be circulating around this. Okay, body fluids or our osmolarity in our blood is consisting of how much osmolarity? 300 milli. Okay, remember that value. Now, yes, this is finished. Basic value of osmolarity and the concept of what is hyperosmolar. Okay, now we already know that in a cell, look at this cell, everybody. In a cell, when sodium is present in higher amounts, what will happen if we are comparing with surroundings? This is more, sodium is more inside this cell, so it will move from higher concentration to lower concentration. This we already know. Now what about water? Look over here. What about water? Tell me. It will move from low osmolar area to, tell me, high osmolar area when we compare it with sodium ions. Do you understand this? This is basic concepts. This we will be continuing deeply in our today's session. So what are the basic thing about osmolarity? Tell me. When we compare it with surroundings, if the solute is more inside a cell apart from the surroundings, we will consider this as hyperosmolar. This is done. What is the normal osmolarity in our body fluids and blood? 300 osmolarity. With respect to this, the urine also should maintain our osmolarity at 300 osmoliters. Okay, have you understood this? Yes. Apart from this, I just want you to consider this is over. Okay, osmolarity concept is over. Now basic things, concentration and dilution. What do I mean by concentration and dilution? See, for example, if this is our renal tubule, okay, I will draw the structure, do not worry. Just for example, to understand this, when there is more amount of sodium ions or when there is more amount of solute when compared with water, what will we call this? This tubule is concentrated. This tubule is concentrated. That's what I'm trying to say. Okay, this is known as concentrated. But when we compare it with a renal tubule where there is more amount of water and less amount of solute and more amount of water, what we'll tell this? Yes, we will tell this as diluted or dilution, diluted tubule or dilution. Okay, so now have you understood this till now? Basic things, osmolarity, concentration, dilution. Tell me fast in the chat box, please. I have to hurry. Who is coordinating? Nusra, just tell me now if they have any doubts in these basics.
Yes, I will. Sure. No, they are clear. You can move ahead.
Yes. Thank you. Let's proceed fast. Okay. Now, before today in the WhatsApp group, I have sent a perfect pro forma of how I will be continuing this topic. So now, what was the first question I had asked you guys? Yes. Why? We need to know why does kidney sometimes produces a concentrated amount of urine or a diluted amount of urine? Tell me. Why does it produce sometimes concentrated amount of urine or diluted amount of urine? See, the reason for this is our kidney's function is to regulate the osmolarity. That's why I will give a term known as osmoregulation. Have you understood this? Yes. Its main function is to osmoregulate. Okay, that's why it does osmoregulation in our body. So now what have I told you? Normally how much the value is? Yes, normally it is 300, right? So now when I'm telling you, focus carefully that if in urine or in blood the value goes more than 300, then what will I call it? I will call it as hyperosmolar. Okay, hyperosmolar. Whenever there is increase in the osmolarity more than 300, what will I call it? Hyperosmolar. Have you understood this? Yes, simple, nothing magic about this. Let's see if it goes less than 300 milliosmoliters. Tell me. We will call it as hypoosmolarity or hypoosmolar. Okay, hypo. Okay, this was hyper, this is hypo. More than 300, hyperosmolar. Less than 300, hypoosmolar. Both in urine. Sorry. I think this is a problem. Yeah, both in urine as well as in blood. when it is more than 300, when the value goes more than 300, we will tell it as hyperosmolar, and when it is less than 300, we will tell it as hypoosmolar, both in urine as well as in blood. Have you understood this? Yes. So now what did I tell you? What is the function of our kidney? Yes, it will osmoregulate. So whenever there is a change in this value, whenever there is a change in this normal value, if there is some alteration in this normal value, our kidney will come into action. Have you understood this? Yes. Osmoregulate. It will osmoregulate. Now have you understood this? Like, for example, let me tell you the question. Let's repeat the question. Why does kidney produce dilated or concentrated urine? Let's consider two examples. There is a person who is drinking water. Okay, who's drinking water excessively. What will happen when he's drinking water excessively? That we have to see a scenario situation. And another example is a person is lost in a desert or has dehydrated for a very long time. What will happen to his urine? We will consider two examples now. Okay, let's focus on what happens in when the person drinks water excessively. See, what have I told you? Normally it is 300 osmoliters, okay, milliosmoliters. Now we will forget about this. Now this fellow is drinking water excessively. So now what will our body do? Tell me. This is our blood vessel, for example, okay, and this is our kidney, for example, okay, kidney, for example, okay. Now tell me guys, now tell me, when the blood is receiving more amount of water, obviously the blood will receive more water when you're drinking excessively. So now I'll put an arrow here. So blood is increased in the water is increased in the blood vessels. Now since the water is increased in the blood vessels, the kidney also has to filter a lot of blood with water, right? Water is entering more into the blood vessels because we have drank in excessively. Okay, we have drank in excessively. Now we already know that the kidney is supplied by, tell me, renal artery, and then renal vein will go, right? So this is our renal artery. Suppose this vessel is the renal artery. So now let's just rub off these basic things. Yes. Now what have I told you? Now let's take this vessel and put it in our bigger picture, right? So now our kidney is receiving a lot of water, okay, a lot of water, but it has to maintain at 300, right? It has to maintain at 300 or not? Tell me guys. Yes, it has to maintain at 300. What will happen in the kidney? Let me tell you what will happen in the kidney if the water is increasing and the solute is remaining same. Tell me what will happen. Tell me what will happen, guys. Yes, it will become hypoosmolar. Remember, I have told you over there in that concept, whenever it is, whenever the sodium ions are more and water is at this level, and okay, we will consider as hyperosmolar. But now when I'm telling you for example that there are two sodiums and two waters, okay, now I'm considering this as 300. Now this fellow has drank in a lot of blood, so now what will I replace this sodium ions with? A lot of water, right? I will not replace them. Water is coming off excessively, sodium remains the same, but water is more and sodium remains the same. So what will happen to this value? Tell me guys. Yes, what is the value? Osmolarity value comes from what? Solute, right? It will not come from water. Water is solvent. Solute particles will produce a osmolar value. That's why it will become hypoosmolar. That's why it will become 100 or 200. Now what is this value? Hypoosmolar value. So now if it is becoming hypoosmolar, what can the kidney do? What can the kidney do? Tell me. It has only one option. It has to push this water outside so that this value goes back to 300. Did you get this? Did you get this? See, this kidney fellow cannot do anything to the sodium ions, right? Sodium ions are remaining same. There is no change in sodium ions. Water has come excessively in the body, so it has to excrete more amount of water so that it maintains it at 300 osmoliters. Did you understand this? Did you understand this, that water is getting excreted? Why? Because more amount of water has entered the blood, more amount of water has entered the kidney for it to filter, and then more amount of water will excrete outside. Why? Because it has to maintain at 300, right? If it doesn't maintain at 300, there will be accumulation of water or accumulation of toxic products. There is difference, right? Either there will be accumulation of water or there will be accumulation of toxic products. So there will be a variation in osmolarity and that will cause disturbance, right? But our God has given us the regulatory mechanisms of how to balance the disturbance which occurs. So did you understand how the drinking water concept is over? Have you understood how it will be a hypoosmolar and then it will secrete more water outside in order to maintain the 300? Okay. This you have understood. Now let's come to the second example. This fellow is in a desert. So now this fellow has no source of water, no source of water. Now let me tell you guys, since he has no source of water, what will happen in the blood vessel? Nothing will happen. There is no water coming. He's not drinking any water. So now the kidney has limited amount of water. The kidney has limited amount of water. Plus this fellow is in the desert, so he's losing water also. He's losing water. So he's losing water through what? Sweating, right? He's losing water through sweating. So there are certain things. These are regulatory actions. So now we'll focus on kidney here. So now kidney has limited amount of water. But what is happening? What is happening? He's staying there. He's lost in desert. So he will eat something. He'll try to eat something, or he must have eaten before he got lost, right? So that eaten food will accumulate or not? Accumulate or not? That eaten food when compared with water. See, he will eat something, but he has no source of water. Okay, so the solutes is increasing, I'm telling. Okay, the solutes will increase, but the water remains the same. So what is happening here? What is happening here? Let's draw the tubule. Solutes are increasing, but water is remaining same in the body. So now this fellow is getting concentrated. So if he's getting concentrated, what will happen? What will I call this renal tubule when it gets concentrated like this? Water remains same, but solutes increase because he will eat something, or his body will degrade his fat or something like that, right? Some mechanism is there to produce energy in the body or excretory products in the body, but out source of water is closed. So water is remaining limited, but solutes will increase. So in the renal tubule, it will get concentrated. So I will call this phenomena as hyperosmolar, right? So now, since it is hyperosmolar, what can the kidney do? Tell me, what can the kidney do to maintain at 300? What does this fellow has in hands now? Yes, this fellow has now sodium in its hands. It does not have any water. It has sodium in its hands. So what will this fellow do? Tell me. Yes, tell me, in order to maintain that. It will cause less secretion of water. Okay. He will keep sodium with himself. Okay. He will keep sodium with himself, but water will be excreted less. Okay. Water will be excreted less. Sodium will remain same. So he already I've told you that sodium nothing can happen, right? There will be reabsorption and all that. I will come to that topic. But what will happen, in order to maintain this osmolarity, he will not secrete the water, and that's how the osmolarity will be remained at 300. Okay. See, normally what is happening here? Sodium has increased, right? So what will happen? It will not be 300. It will become 600, or it will become 800. But the kidney has to maintain it at 300. So what can this fellow do? He can reabsorb the water. Okay, he can reabsorb the water, and he can reduce the secretion of water, and he can bring this value down to 300. Have you understood this concept? Have you understood the concept? It's just a matter of sodium and water balance. Okay, if just for your understanding, I'm telling, there are more solutes, but just as a common solute example, sodium is the thing. What will happen now? Tell me, if I drank water excessively, I'm drawing in red. Water is excess, sodium is remaining normal. Okay, so what this fellow is doing? He will excrete more water outside. This is done. This you have understood. But now what is happening? Water is decreasing, but solute is increasing. So now what can this fellow do? In order to maintain that, he will excrete less amount of water, so that less amount of water is secreted. Okay, I will not put this down now. Less amount of water is excreted, sorry, so that this is balanced by water reabsorption, and that will cause it to come back to 300 osmolators. Have you understood this? Yes. Why does sometimes there is production of concentrated urine, and why there is sometimes presence of diluted urine? Have you understood this? These are the two common reasons. We'll be going into the details. How does this occur? Now we have answered why does this occur, because sometimes the person drinks excessively, or sometimes he's dehydrated. We have answered the why. Now next part of my proforma. What was the next part of my proforma? Yes. How does it occur? Let's go into how does it occur. Have you understood this till now?
Yes, clear, Sadat. No doubts till now.
Yeah.
It's 7:30. Okay.
Yeah. Okay. When blood dilutes, urine also tries to dilute. When blood concentrates, urine also concentrates. So that's why, in order to maintain blood at 300 and urine at 300, those phenomena occurs. Okay, that's all. This is nothing. You don't need to. It's simple. Okay. Now let's go into the deep details of how does it occur. Okay, mechanism of how does it occur, mechanism of concentration or dilution. Now listen up carefully, I am not discussing now dilution. Let's forget about dilution. Okay, let's focus on our concentration of urine. What have you understood in concentration of urine? We have to take the example of the desert fellow. Now, how does the concentration occur? On what factors does it depend? Yes, right. Take this down, everybody. Take this down in your notes. Mechanism of concentration. This is the essential part. Okay, I have made the notes for you guys, but for understanding, you have to take down notes. So now, hyperosmolarity of medulla. Okay, medulla. Okay, medulla or yeah, medulla. Okay, have you written this down? Yes, you have written this down. Role of ADH. Yes. I will be explaining. Do not worry. So now, mechanism of concentration is dependent on what factors? Tell me, everybody. Hyperosmolarity of medulla and role of ADH hormone. Okay, ADH hormone, antidiuretic hormone. Okay, antidiuretic hormone. These are the two mechanisms in which our urine gets concentrated so that amount of water is less. Okay, amount of water is less in our urine. Okay, so that we can conserve as much as water we need for our body. Okay, suppose we are in a desert, right? So now let's focus in here. Okay, for now let's forget about this. What are the two things I've told you to forget about? Dilution part and this antidiuretic hormone part. Let's not focus here, let's focus over here. Yes, we are focusing over here, my friends. Let's come down here, take down the notes now. Yes, hyperosmolarity of medulla. What do I mean by this? See, in our kidney, sorry about the typo. Yes, in our kidney, guys, we already know that there will be a renal pyramid, right? And then we have medulla, and then we have this pelvis region, right? So now, this is our cortex, renal cortex. This is our renal medulla, okay, and this is our pelvis, right? We're not focusing there. So now what I'm trying to tell you guys is, what did I write over here? What did I write over just above me? I'll not go above, tell me. Yeah, so I have written that hyperosmolarity of medulla is required for maintenance of our concentration of urine, required for our concentration of urine. So now what do I mean by hyperosmolarity of medulla? Carefully observe here, everybody, carefully observe here. See, when I'm talking about medulla or renal cortex, we have this cortex and medulla, right? So now, apart from the nephrons, I will come to nephrons. Apart from nephrons, which will be like this and like this, we'll come to that. Let's not talk about that. Apart from nephrons, we have areas called as interstitium, right? Renal interstitium. It's nothing but the tissue of kidney, right? Apart from the nephrons, I will come to nephrons, but remember that apart from nephrons, what is there? Interstitium. And in interstitium also we have peritubular capillaries. Have you understood till here, guys? Have you understood the structure till here? Yes, you have. What have you understood? Yes, I have told what? Yes, I have told that in the renal cortex and medulla, apart from the nephron, which I'll be teaching you now, do not worry. Apart from nephron, there is interstitium and there is peritubular capillaries. Have you understood this? You have understood this. Now, what do I mean by? 1 second, it's not rubbing off. Yeah. So now I will magnify the image for your understanding. I will magnify this image for your understanding. See, I'm taking this triangle. I'm taking one portion of the kidney. It will be like this, right? We know this basics. I'm taking one portion and I'm magnifying it. So now when I will magnify it like this, yes. When I'm magnifying like this, what is happening? Tell me. Yes. So now I'm labeling this as our, yes, this is our cortex, right? And this is our medulla, right? So now I want to draw the nephron, to the favorite part. What is nephron? Nephron is the filtration unit of our kidney, very important part of our body. Without this, we could not urinate perfectly, right? So now I'll just draw a rough diagram and then yes. Okay, now light. What is this nephron? Tell me. Yes, this is the filtration unit of our body. Now have you understood this? I have magnified this triangle over here. You have understood this. Now what do I mean by medulla hyperosmolarity? See, apart from nephron, what did I tell you? Yes, there will be interstitium. Interstitium is nothing but this area, this area, this area, and all these areas is interstitium. Let's go back. Let's remove all that blue parts, which is nothing but interstitium. Now let me focus on the interstitium. Let's zoom in the interstitium. Now, what am I telling that there is hyperosmolarity in interstitium? See, in the cortex, the osmolarity will be 300. Okay, draw this rough diagram if you want to for your understanding. But as we go down progressively into the medulla, okay, as we go down progressively into the medulla, the osmolarity increases. The osmolarity increases like this. Understood this? Yes, you have understood this. So now I will be telling you why this osmolarity is increasing. I will be telling you what is the importance of this increase in the in the osmolarity. Okay, for now you have to understand that we need this hyperosmolarity of medulla. This is the medulla, right? This whole part is, this is the outer medulla, this is the inner medulla. Okay, this is the renal cortex. So now outer medulla and inner medulla, you can see how it is increasing progressively. Hyperosmolarity meaning what is the meaning of hyperosmolarity? Yes, in the interstitium over here there will be more amount of solutes, right? There are more amount of solutes, or you can say there is less amount of water. Anyhow you can tell that, right? Till now you have understood why, how this what I mean by hyperosmolarity medulla, you have understood. Now I will explain how it's occurring. Why do we need this, right? Let's go. See, now for you to understand this, I will draw the whole nephron. For now, for few people who have not understood, there are few people who do not know the structure perfectly. So I will just draw for their understanding. Do not worry. Okay. So now, yes, I will just label the diagram so that you can understand completely. So this is our Bowman's capsule, right? In the Bowman's capsule, what will be there? See, when the renal artery is coming, into the kidney, they will form certain capillaries over here. They will join all like this, arterioles, okay, and they will produce like this. Now I will give a name to this as afferent arteriole, and then I will give a name to this as efferent arteriole. You know this concept, right? What am I calling this tuft of capillaries? Glomerulus. I'm calling this as glomerulus. Okay, we all know this. We have learned in inter. There's nothing new. Bowman's capsule over. Now, what is this? This is the PCT, proximal convoluted tubule. Now, this part is our descending limb, right? Descending limb. Okay, and this is our loop, and this is our ascending limb. Ascending limb I will describe one second. See, descending limb also has thick and thin parts, but we will not consider that because it's not very important. For now, you should know that there is thick and thin descending part, but you should not consider. What is this? Descending limb, loop, ascending limb, all these structures come in handy. Okay, loop of Henle. Okay, so there is descending loop of Henle, there is this part, and there is ascending part. Okay, now there is, you can just do not call limb, just call descending part. Okay, descending part, ascending part. Okay, now we will rub all this and we will jump into the next part. Now you have understood the, yeah, focus over here. This part is our thin part of the ascending limb, and this part is the thick part. Okay, you can see the difference, right? This part is the thin part, this part is the thick part of the ascending limb, right? Okay, now I will divide this into two. Again, when you go above, this is the early part of the distal tube. Okay, distal tube. One second. Okay, this is the late part of the distal tube, and this is our collecting duct. Okay, sorry for the handwriting. There's some error coming over here. Okay, so now you have understood the basic structure. Yes, now let's go deep into our studying about the interstitium and how it occurs. Now, what have we discussed till now? Yes, hyperosmolarity. Hyperosmolarity, what we have discussed? The medullary interstitium. Now remember, I have discussed about till now hyperosmolarity. Okay, now I want to ask you guys, hyperosmolarity I have discussed. Okay, but now I told you how it is. I told you need to ask these questions: how it is occurring and why do we need hyperosmolarity? Okay, now structure is over, everything about osmolarity is over. Now we will be discussing how this medullary hyperosmolarity is occurring. Now let's focus over here. I'm again drawing the, yes, I'm again drawing the Yes. Yes. Okay. Now, focus over here, guys. I will be writing certain things. Do not get confused. In my proforma also I had written that. But now you can understand here. First, hyperosmolarity, how does it get produced? First, it needs to be produced. Okay. First, it needs to be produced, or it has to be, uh, right, never mind about that. Okay, it needs to be produced, right? First, it has to be produced, because I have explained to you how the medullary interstitium is increased in osmolarity, and then we need maintenance of that osmolarity. Have you understood this till now? Yes, we need two things. We need production of the hyperosmolarity. We will be seeing how the osmolarity will be produced, and then we will be seeing how the maintenance of the hyperosmolarity occurs. Let's go in detail a little bit. What are the two ways in which this will occur? I'm giving names. Note this down. Note this down. First name for production is counter current multiplier. Yes, yes. Counter current multiplier is nothing but our loop of Henle. Okay, our loop of Henle. Noted this down, guys. It is helping in production of the hyperosmolarity. Another thing is about urea recycling. Note this down, guys. Note this down. I have made notes. Everything will be understood. You do not have to worry. Okay. For now, you have to only understand the concept. Okay. Right. Have you written this down? Counter current multiplier, which is nothing but loop of Henle, and urea recycling. I will explain. Do not worry. Maintenance. Once it is produced, we need maintenance of that hyperosmolarity. That's why I'm giving another way. Another method is there. Counter current. Sorry about that. Yeah, counter current exchanger. Okay, exchanger. So now I am giving a name to this as vasa recta. Vasa recta. I will be coming to all the details. Just note this down, everybody. Now what have you understood here? Yes, first we need production of the osmolarity, then we need maintenance of the osmolarity. How is the production? Yes, from loop of Henle, from urea recycling, and then we need vasa recta for maintenance of the osmolarity. Let's come over here. Let's come over here. See now. See now. Let's just jump into it. Let's see. This is our blood vessels. Okay. It brings products, right? This blood vessels brings products. So now there is a connection between this Bowman's capsule and the glomerulus. What will happen? What did I tell you? What is the osmolarity of this? Tell me. 300 milliosmolars, right? 300 milliosmolars. What will happen here is the solute which has to be filtered will enter into this. Yes, you have understood this. You have understood this? Yes. This is the afferent, this is the efferent, but the solutes which have to be filtered will enter into this. Large molecules will not enter. Very large molecules cannot enter. There will be slit pores which will allow it to enter into the Bowman's capsule. Have you understood here? Now I will put my osmolarity over here. 300 only it will be. Okay. 300 only it will be. Okay. Now we will focus on the PCT. Focus over here in the PCT, guys. Please focus over here. I'm sorry, it may be a little bit boring, but you have to understand this concept, because most of these first years will not understand this and they will just go to the exam. Okay. Now I'm telling you that the PCT osmolarity is, what will happen in PCT. Now focus over here. See, PCT is easily permeable through everything. Okay, it will cause permeability is not an issue in PCT. He's bindas. So what will happen here? All the molecules solutes which came in the from the Bowman's capsule, the large molecules and the most important parts which we need, okay, whatever we need we will reabsorb. Did you understand this concept? Whatever we need we will reabsorb, right? We will reabsorb, and what we do not need we will secrete it off, or we will excrete it off. Okay, so now what is this arrow for? Yes, I'm giving this arrow for our sodium chloride. Okay, or sodium, just nothing. Okay, I'll just put sodium. Okay, sodium is coming off, water is coming off, glucose is coming off, amino acids are coming off. What do I mean by coming off? Yes, they are reabsorbed. Most of these solutes are getting reabsorbed in the PCT. Okay, did you understand this? Yes, in the interstitium they are entering, right? Sodium, water. Okay, you can also put chloride, you can put everything. Most of the major solutes will enter, get reabsorbed into the medullary interstitium. Okay, so now I just want to focus on a very, very important concept. Hear me out for a second. See, the amount of sodium and all the solutes, when we compare it with water, okay, which is getting reabsorbed, okay, which is getting reabsorbed, it will be same when we are comparing with water. So let me put like a ratio like this: solute is to water. Okay, I'm telling you that this amount of solute which is getting absorbed, reabsorbed, is equal to the amount of water getting reabsorbed, because PCT is permeable to all, everything. Okay, it is permeable to water as well as solutes. So now what is happening? Why am I telling you about the solutes and water? See, remember the box, sodium and water? Yes, if they are in equal amounts, the osmolarity will remain same or not? See, when the sodium and other solutes, when compared with water, if they are in equal amounts, they will remain same or not? Osmolarity will remain same or not? It will remain same. Suppose 300, right? And I'm taking out equal amounts of sodium and I'm taking out equal amounts of water. Still, the osmolarity will remain the same, my friends. Did you understand this concept? Did you understand this concept? Why it will remain the same even after there is reabsorption of water and solute? Because equal amounts of things are getting reabsorbed. So, have you understood till here? Yes, you have understood the PCT, right? Sodium, water, glucose, amino acids, chlorides, everything is getting reabsorbed. Okay, everything is getting reabsorbed. Everything is in the notes, my friends. Everything is in the notes. You do not have to worry. So now, why did I focus so much on the osmolarity? Because I would love to write here 300. Did you get this? Did you get this? Even after the tubular fluid, whatever is going through this tubules, I will call it as tubular fluid. Whenever the tubular fluid is passing through this, it, even though there is reabsorption of major 80% of the things are getting reabsorbed, still the osmolarity remains the same. Why? Means that reason you should give. Did you understand till here? Yes, PCT is over, my friends. PCT is over. Okay, any doubts still here in PCT, my friends? Nusrat, Arvaz, anybody?
No, no doubt, Sadat, you are going at a very nice pace. No doubt still here.
Thank you, thank you.
Reason, it
Let's proceed.
seems.
Let's proceed,
Reason
my.
once again. Which reason, Sadia? Which
For what?
reason? Yeah,
For what?
don't know. She is not accurate in her question. Sadia, can you please write down which,
Okay.
okay, about the 300 milliosmoles, what is the reason?
Okay, I just explained. I will explain in a bit again. See, when I am putting these arrows in the PCT, okay, see what is happening is come from above. From blood 300, here also 300, because it's coming with the same amount of fill rate. Okay. Now when we are passing through the PCT, what is happening? What are the blue arrows for? Yes, the blue arrows are for sodium, water, amino acids, chlorides, everything. Okay. What am I doing here? What am I doing here? Remember what I have told you in the starting? Starting, what did I tell you about the cell? Everything I will take from the starting. In the starting, whatever I have explained, I will take it into the detailed concepts. So now, remember that sodium water concept? Yes. So sodium, if it is in equal amounts and water is in equal amounts, I'm giving a value of 300. Okay. For example, for our understanding. Now, what did I tell you? I'm telling you that what am I doing here is I'm taking out few amount of sodium outside and equal amounts of water outside. Okay, equal amount of sodium, all the solutes with, and water also equal amounts. So sodium and water I'm taking out as equal amounts. So what is the remaining? What is remaining in the cell? Suppose there were 100 sodium in the cell, 100 sodium chlorides. Don't see the powers. Just for your understanding, 100 amount of solutes. For your understanding, 100 amount of solute was present and 100 molecules of water was present. I am removing 50 solutes outside. I am removing 50 molecules of water outside. So what is remaining inside? 50 amounts of solute, 50 amounts of solute and 50 amounts of water. So aren't they remaining the same, my friend? Aren't they remaining same, Sadia? They're remaining the same. So osmolarity will be still 300. That's the main concept. Okay. I think
Imagine
that's
it like a seesaw. Imagine it like a seesaw. You have sodium on one side, you have water on one side. So if you imagine them that they are two groups and you have equal number of members, take it for example 5. If equal number, one from sodium, one from water is getting down, the seesaw will be balanced. If for example 4 are getting down from sodium and only one from water, so then there will be imbalance and change in osmolarity. We get hypoosmolality. Okay, about the time
Okay.
it's 7:50, Sadat, and sir has some work, and we will have to take a leave from him. Sir will have to take leave. Okay, sir, before
Sure,
going,
sure.
anything to say? Panelist also can say.
Yeah, Sadat is doing very good. Alhamdulillah. He is covering all the topics, all the points, and pace is also good. Alhamdulillah,
Thank you, sir. Thank you.
uh, he's as good as a professor now. Alhamdulillah. He's
Thank you,
covering.
sir. Thank
One more
you.
request is that, so just I want to know, is my suggestion that you have to cover important topics actually, exam based, okay, which are usually
Yes, sir.
asked in
Yes,
exams,
sir.
long questions,
Yes,
you
sir. We are
cover those
combining.
topics. Huh.
Yes, sir.
Okay, so it's my suggestion.
Yes, sir.
Rest,
Yes, sir.
you are doing
We have taken
fantastic
all the very,
job.
very important topics, and we have taken till now all the classes on the main important LAQs and SAQs, sir.
Yeah, that's good. Huh? That should be your selection criteria. And you're doing very good, fantastic. You have covered all the points,
Thank you. Thank you very
explain
much,
all the
sir, for
points,
coming. It's an honor, sir. Thank you very much.
and you will improve a lot. If this is your
Thank you.
caliber now, so I can think you will be you will do lot better than this, inshallah, in future
Inshallah.
classes. So fantastic.
Definitely, sir.
Keep it up. Okay,
Thank you very
okay,
much.
thank you. You can
Thank you,
continue with
sir.
your.
Thank you for being with us.
Okay, thank you. Okay,
Thank
Thank
you.
you,
Sadat.
sir. Thank you, sir.
Thank you
Okay,
very much.
okay. दुआ करिए मेरे लिए इंशाल्लाह.
Definitely, sir. Definitely. Inshallah.
Okay, Allah. Assalamu alaikum.
Islam. Okay. I think sir has left. I will proceed now, Nusrat.
Yeah, sure. Yeah,
Nusrat?
sure.
Yeah.
Yes, you
Yeah.
can.
Yeah. Yes. Now everybody focus over here. See, we have covered about the PCT. Now what I want all of you to do is, suppose we will take this nephron as the person who is filtering for the first time. Okay, this fellow is filtering for the first time. What did I tell you? Here it will be 1200. I have told you, right? Let's forget about all that. Let's consider that this fellow is 300, 300. Okay, we are considering it as 300, 300, 300. Okay, stop over here. Stop in the thick part. What is happening in the thick part? From here on, there will be changes, right? I'm telling you how it occurs if it is occurring for the first time. Hypothetically, okay? What happens in the thick ascending part of the renal tubule? Focus over here. I just want you to focus on this part, okay? So before going into this, my friends, can all of you draw this diagram for me, please? Please draw it in your notes or somewhere, wherever you want to, okay? Just draw it for your understanding purposes, okay? Please draw it for your understanding purposes. Okay. So now what happens here is, sorry, yeah, please draw this diagram, everybody. I'm not drawing the thick part of the descending segment, okay? Because there's not much significant usage of that to specifically mention. Please draw this diagram, okay? See, when it enters into the PCT and up to the middle part of the loop of Henle, see the blue lighted part? Yes, this is water permeable. Please draw this diagram, everybody. Yes, water permeable. Now I will take a different color. Yes, I will take a certain sad color or something. This part from here up to here till the early part of the distal tubule. Yes, the brown part. Write this down. This is water impermeable. Okay, very, very important concept for you guys to learn. Please, you have to know this. And then I will be taking another we can't forget this part, right? I will draw it as a diagram like this design. Okay, label this now, guys. Yes, this is regulated by ADH. We will come to this. For now, note this down. Regulated by ADH for water permeability. Yes, write this down, everybody. See, if I tell you now this, you will understand it very easily when we are going in the details. Till now we have covered the PCT part, right? Where whatever is permeable, but when we will come over here, it is impermeable. So it's a very important concept for you guys to know. And when we come to this part, we need ADH for water permeability. I will come to that also. So you have drawn this diagram or taken a screenshot, everybody? Yes, you have taken this. You have understood this. Now, where was I, my friends? Yes. I think few people again they are getting nervous or something. I have not covered, or I think yes, for your satisfaction, I have made the notes. You do not have to worry. It's a pure LAQ, so I have made the notes. Okay. I have to always remind you guys that I have made the notes so that you are not scared of the topic. Okay. So now, yeah, sorry. Over here, focus over here. We are in the thick ascending part. Now, what I want to tell you guys is this part, something happens. This is the first time this nephron is working, right? So I have put in 300, 300, 300. Just to make sure if anybody wants to know where I have referred this, I have seen Dr. Najib's videos and I followed Sembulingam. Okay. Okay. Now, see, I want to tell you certain about these cells over here. This is a intraluminal cell. Intraluminal cell. Okay. This fellow can connect between the lumen and the this cell. It's anything between this fellow. There is one thing. There is some chemistry. Okay. Chemistry between what? Between the lumen of the tubule, thick ascending part, and between the lumen of the cell of this cell, intraluminal cell. Another type of cells are surface cells. Okay, these are surface cells. Okay, these surface cells also have certain type of channels or receptors, right? Now, most important role starts from here, my friends. Most important role starts from here. Intraluminal cell, surface cells. Okay, what happens over here? Let's rub all this. Let's rub all this. Okay. I will zoom in for your understanding and I will draw this dabba very big. It's one cell. It's a one cell which I'm drawing now. But for your understanding, yes, this is the surface cell and this I will draw as a intraluminal cell. Till now, have you understood this? Yes, you have understood. Okay. Let's rub this off. Okay. Yeah. This is the interstitium. Okay. I might be going a little bit slow, but please, this is a really important. I have to go in detail, right? Okay, so now I want all of you to focus over here is that we have a sodium potassium ATPase over here. Okay, all over the cell. We have sodium. This is not dropping off. Okay, we have sodium potassium. Yeah, sodium potassium ATPase. What does this fellow do? Tell me, everybody. I have taken the class. Yes, sodium is pushed out actively. Did you understand? This is the surface cell we are talking about. Surface cell on the ascending part of the tubule. Sodium potassium ATPase causes sodium to go outside. We can talk about the potassium which will go inside, but see, the most important part is sodium, so we'll focus only on sodium. But potassium is going inside. Do not forget about that. 3 sodium, 2 potassium. We'll not go in details, but sodium is going outside now. Over. But in the intraluminal cell, what happens is we have another fellow who is channeling certain things. This fellow has a channel called as sodium potassium 2 chloride. What does this do? From the intralumen, where the solute is present, where the tubular fluid is coming from the PCT, it's coming like this, right? Yes, it will contain all this sodium, chlorine, right? This fellow will go over here into the surface cell. Have you understood this, my friends? Have you understood this? Please tell me, have you understood this? Chat box.
Yes, sir, you are crystal clear. Go ahead.
Thank you, madam. Okay. So sodium, chlorine are coming into the surface cell from this channel, and that sodium is going outside. What is this, my fellows? Tell me, what is this? Interstitium, right? Interstitium, na? I rub that off. But I have zoomed in, right, for your understanding. Yes, yes. Did you understand this? Let's draw the descending loop here, like this. Yeah. This, did you understand? So the interstitium is getting filled with what, my friends? Sodium, right? It's getting filled by sodium. So what is the interstitium as in general getting filled by? Solute. it's getting concentrated, right? The interstitium is getting concentrated. So now this 300 over here, focus on this value, my friends. Please focus on this 300, my friends, please. What will happen to this 300? Tell me. If it goes further over here, it will decrease or not? Yes, it will decrease 200, right? Sodium is getting lost. Water is remaining same because this channel will not take in water. Only it will take sodium, potassium and chlorine. So that sodium is going outside. Do not focus on potassium. Potassium will not be a major, will not play at all a major role in this. Okay. Chlorine also will not. Chlorine is also actually going outside over here like this. Chlorine also. So basically solute is getting, so chlorine has separate channels on the surface cell. So chlorine also getting accumulated. So tell me, let me rub all this, my friends. Let me rub all this. It's happening for the first time. So now, remember, I have told you that apart from the tubules, what all is there? Apart from the interstitium and the tubules, there will be capillaries. There will be capillaries all around the interstitium, blood vessels, right? These capillaries will be around everywhere in our body. How the capillaries will be? On every inch there will be capillaries, right? So the capillaries will be containing how much? Tell me. 300, right? 300. So now since this capillaries are here like this and the interstitium is also there, interstitium is getting sodium ions, so these capillaries also are also there. So what will happen, as in general, when we are not considering this capillaries and we are considering it as a whole interstitium? Tell me. Yes, this 300 will become 400. Have you understood this, my friends? Have you understood this? Interstitium will also contain 300, right? Because of the blood supply to interstitium also. The tubules also receive blood, the interstitium also receives blood. But the interstitium is also containing 300. The renal tubular fluid also is cutting 300. But what happens is sodium is entering a lot, so it will become 400. And this will become 200. Okay, I think you have understood this. Now, the funda of this interstitial, but it has to reach 1200, right? It's not reaching 1200 now. What is happening here is, see, why are we giving it a name as counter current? Tell me why are we giving it as a counter current name? See, the fluid is coming from this direction, okay? Then it is going in the opposite direction. So what will we give a name? We'll give this name only, counter current, right? Opposite to the current. The current is coming from this direction, but it is going opposite. So this mechanism, it's happening by nature. God has given this, that's why we are giving a name as counter current. Now the name which I had given extra was multiplier. Let's go into detail of multiplier. I'm going a bit slow, let's go a bit fast. So imagine that this nephron was put straight like this. Okay, this was the thick part and it was put straight. Naturally, if it was straight, what will happen is we will not call it as counter current. First point. Second point is, outer side it will make it as 400 and inner it will make it as 200. When it is going like this in this direction, 200 it will become, right? This will become 400. So the difference is how much? Tell me. Difference is 200, right? 400 is in the interstitium, this is in the distal tubule, and it is difference is 200. See, normally if it is in a straight path, it will become only, there will be only a 200 gradient difference. Okay, this will become 400 and 200, but this is not enough. This is not enough for concentration or filtration. Okay, this is not enough. This osmolarity is not enough. We don't want medulla concentration to be only 400. It has to be 1200, right? So what am I doing? What did God do? Not I. What did God tell me? Yes, he has taken this nephron and he has looped it like this. Yes, and then the collecting tubule. So since he has looped it like this, the process gets repeated. It gets repeated, my friends. It gets repeated. How it gets repeated? Come over here. Come over here. Yes, yes. See now, up till now we had focused over this part, thick ascending part. Let me draw another diagram because it's getting fussier. In the exam, you should draw only one diagram, one big diagram in one whole page so that it covers everything. But you have to draw many diagrams also, small diagrams. So this is our, yes, thick part I'm not drawing now. Just focus over here. So now till now, what did you understand? Sodium is coming, it become 400. But blood is coming till now, na 300 it will be. Blood still comes. It will never stop. This will never stop. So now in the PCT, it is still 300. Yes. Now this part, remember what did I tell you? Up till here, how what it is? Water permeable. Remember that concept? Yes, up till here it is water permeable, this whole part. It is water permeable. So when it compares 300 with 400, see now what happens here. Remember that small box for I had told you what will happen when we consider that box. Water is outside and here it is sodium is high. Okay, and there is very less water. Water moves from low osmolar area to high osmolar area. Yes, this is the basic concept in the starting of the class. You have understood this concept. So now what will happen over here? What will happen here over here? Since this part is permeable to water, what will happen? This water will move from lower osmolar area to higher osmolar area. It will go like this. Water is going outside. Water is going outside. Another concept comes over here, my friends. Pause over here. Wait. What will happen? Since water is going outside, what will happen inside? Focus over here inside. Yes, come over here in the inside. Water is going outside, my friends. What will happen to the solutes here? They will get concentrated, my friends. Since they are getting concentrated, what will be the value? The value will be same as the surrounding. It will be same as the surrounding, because how much the water is lost, it will become concentrated that much, right? See, I will give for example, suppose 300 it is there in the interstitium. It requires two water molecules. So two water molecules will go outside. Sorry, I'll make this as 400. This is 400, this is 300, right? So in 300 tubular fluid, two water molecules are required to go outside. So when two water molecules go outside, okay, so this fellow will still remain 400, but two water molecules will go outside. This fellow will become 400. Why this fellow will become 400? Tell me. Because the solutes remain the same, but the water is going outside. So there is water loss. So what did I tell you? When there is water loss, hyperosmolarity will occur, right? Did you understand this concept? Nusrat, just tell me if they have understood this water going outside from the descending and then the osmolarity getting increased into the loop of Henle. It will become 400 here.
No, you need to repeat it, I guess. They are still ambiguous still.
Okay, okay. Okay, I think I have not covered it nicely. See, do not worry. Nothing specific, scientific about this, my friends. See, this is 300. Okay, what did happen when sodium came from here, from the sodium potassium and the sodium chlorine? It became 400. This you have understood here? You have understood. But remember, I had told you that I will put it in a different color. This is water permeable. Water permeable. So water is allowed to go outside. But when will the water go outside, my friends? That concept I've explained just now. When the solute is more inside, when the solute is more somewhere and the water outside is more, water will move from low solute area to high solute area. Why? Because water moves like that, right? Osmosis, the basic principle which we have learned in the inter, it moves from low concentrated area of solute to high concentrated area. So low concentrate means this is 300, but high concentrated means this is 400, I'm telling. So put that same box over here. Nothing is there. I told you from there PCT it will come like this. 300 only it will be. But now it will be 300. But when this fellow will look over here in the outside from through the window, when he will look, oh my god, it is 400 outside. So this water will in a hurry go outside, right? Water will go outside by the process of osmosis. But what is the next thing I'm saying? Here you're getting confused. What is the next thing I'm saying? See, the next part where I'm telling you that sodium is present, water is present, but now water is going outside in the 400 hyperosmolar area. So this water is gone now. This water is gone. This one molecule is gone. Now I'm telling you about the osmolarity of this cell, mama. I'm telling you about the osmolarity of this cell. I'm not talking about this. What will happen here now? Water is gone. So when water is gone in a cell, what will happen? Solute is increasing now when we are comparing. See, sodium and water, right? Water is going off. Solute will be more. Solute more means osmolarity value will increase. It will become from 300 to 400, right? When we measure, I think you have understood or not. When we remove water from the tubular fluid, when it is 300, water when it goes outside, the solute increases inside. That's why it becomes hyperosmolar, I'm telling. Understood or not?
Um, Sadat, there is a question related to the osmolarity, change of osmolarity of the interstitium in this process.
Yeah,
What
what
is
is the
happening
question?
to the interstitium? What will happen to the
Interstitial, I have
osmolarity
told you,
of
right?
the interstitium?
Exactly. It was here. I have explained it over here in this diagram. See what happened over here? What example did we take? We took the example of first time this nephron is filtering, right? We gave the value of 300, 300, 300, 300, 300 across, but we stopped over here in the thick part. Why did we stop in the thick part? Because this thick part is starting to function as a concentratory mechanism. Why it is occurring as a concentratory mechanism? We have sodium potassium chloride cell in the intraluminal cell. Okay, in the intraluminal cell we have this receptor, and in the surface cell we have sodium potassium ATPase, which I have drawn over here. What will these fellows do? These will push sodium outside. It will push sodium outside, na mama, by active process. So once they will push sodium outside, I told you that the interstitium it will be 300 only. Why interstitium will be 300? Because the peritubular capillaries and all the other capillaries which will be present in the interstitial space, apart from these tubules, apart from the nephron, it will maintain it as a 300 interstitium, right? I told you the whole blood in our body will be 300. So now this interstitium and the peritubular capillaries, when they are present, sodium is coming inside. Sodium is coming actively. So when solute will come inside a cell, what did I tell you? It will become hyperosmolar. That's why I told you to focus in the starting, right? Whenever you focus on the basics, you will be able to understand these concepts. So when sodium is entering into the interstitium, for example, into a cell, osmolarity will increase. Osmolarity is nothing but the amount of solute. Solute is sodium. Sodium is coming into the interstitium. It will become 400. Interstitium is becoming 400. Then what did I tell you? When the interstitium is becoming 400, I took the example of this. I told you that even though this will become 400, still the blood is giving from the glomerulus, still the blood is coming now, still it is filtering. So that will be 300 filter inside the lumen, 300, 300. But now here it is permeable to water. So water will go outside into the, I think he's asking about what will happen when water will come inside. I think, yeah, I shouldn't have explained all that. He or she may be asking why when water comes inside 400. I am coming to that, my friend. I'm
Yeah,
coming to
yeah.
that.
There is
Yeah, I think that is over.
actually,
And
because this is a coordinated work, the nephron will function as well as the peritubular capillaries will also function. And on the whole, matlab, whatever the gradient is fixed for the medulla, that will be maintained. Yeah, go on, Sad.
yeah, I think till now you have understood till where, my friends? Yes, you have understood till here, where I have given you the example of this is becoming 400 and the water is coming over here. Okay, and this is also becoming 400. Till here you have understood. Okay, now he's going 400, 400, 400. Stop now. Stop now over here. Again, what did I tell you? Let's rub these fellows outside. Yes. Now again we will bring that surface cell. Again we'll bring that intraluminal cell. Why are we bringing that fellow again over here? Because he's functioning like that. God has given it to function like that. So now again this sodium potassium ATPase is there. Okay, again this sodium potassium chloride is there, intraluminal cell, surface cell. So now this 400 fellow is coming over here. He's getting more excited. Why? More amount of solute is there, right? Previously it was only 300. Now it is 400. More amount of sodium is there. More amount of sodium will go actively here, and then more amount of sodium will go again into the interstitium. Have you understood this? Have you understood this? So now, since more amount of sodium is coming back with more power because it has become 400, right? 400. Why it became 400? I have explained 2-3 times. Still at the end, if still people did not understand, they can ask. But for now, focus over here. Now, let's rub this. Yes. Again, it is happening. I have told you, right? So now, it was 400. Now what will happen? Again, sodium is coming. Now what is happening? Tell me. Yes. Now it will become 600, my friends. Now it will become 600. Again come to this concept. Again come to this concept. Yes, again I have to draw this for your understanding. Again I have to draw all this, right? So now what did I tell you? Again sodium has come more because it was 400 now. Still it will become 200 because more sodium is going into the interstitium. So now this will become 600. I have told you. Previously it was 400. Why it is becoming 600? Because more amount of sodium is coming into the interstitium, more amount of osmolarity. Again, the whole process begins. Again from PCT, again water will see through the window. This fellow will see, huh? How did this become 600? This fellow is again 400 now. He's only 400 now, right? He's only 400 now. He will look outside. Water will look outside. How is it 600? I have to go. He will go outside. Why he will go outside? This is only 400, but this is 600. From low osmolar area to high osmolar area, that is 600. Water will go outside. Okay, water will go outside. Okay, now since this fellow water has gone outside, what will happen to the intratubular fluid? Tell me, everybody. What will happen to this fellow? This fellow was 400. Now water has gone outside. What will happen to this fellow? Tell me. Yes, now he will become 600. So now, why again? Tell me. Because water is going outside, but the solutes remain same. And when we measure the osmolarity, water is less, sodium has increased. When we compare it like that, right? Like a balance system, as Nusrat has told you, seesaw type. So yeah, water has gone more outside because this was 600 previous now, and then water has gone outside. This will become 600. Now, similarly, like this repeated process, will occur until the loop of Henle becomes 1200 and the interstitium becomes 1200. Till that it will happen. Okay, I think you have understood this reoccurring process. This is only the most important concept, my friends. After that, I will explain other concepts. Have you understood this medullary interstitium, how the hyperosmolarity is occurring? Okay, just put in the chat box any doubts. I will just have a sip of water.
Yes, meanwhile, I'd like to have an announcement that at the end of this month, we'll be having a small 50 question test. I think we'll be deciding on what platform the test should be. I think we can have time limit and we can conduct it with Google form, or we can have it as a session only. You can answer the things in the WhatsApp. We can have something like that, and based upon this, the certificates will be given and also the gift hamper. Yeah, that's what.
Yeah. Okay. I think there are no doubts. So up till now, what have we covered, my friends? Yes, I will just summarize what you have covered. Sodium and the solutes are getting constantly thrown out into the interstitium. Till now you have understood that? Yes, from the thick ascending limb. But what is happening over here, my friends? Here it is permeable to water. That's why water is able to come here. But unlikely in the thick ascending part, as I've shown you in the diagram like this up till here. Right? Let's rub this off now. Up till here, it is not permeable to water. It's only permeable to solutes because of the active channels. That's why water is not able to come outside from the lumen of this tubule, but solutes are able to go outside. So what will you give this phenomena? What will you give a name to this phenomena? Water is remaining more, my friends, but solutes are getting pushed outside. We can't do anything about that. So what did I tell you? When water is getting increased into this area, it is causing dilution of the tubule, but it is causing concentration of the interstitium. Yes, have you understood this retrospective study? If I have told you in the starting, you wouldn't have understood this. What is he telling about concentration of interstitium? What is he telling about dilution of the tubule? See, water is not able to go outside from here, right? It is impermeable. So but in the thick ascending part, sodium and solutes are going able to go outside. So what is happening in the interstitium? Solutes are increasing, right? Solutes are increasing. So I gave a name what in the starting of the class? Yes, concentration will tell that. But in the tubule, inside the lumen of the tubule, what is happening? Water is remaining increased. So we are giving a name as dilution of the tubule, unlike in the concentration of the interstitium. Okay, I think you have understood this dilution and then concentration of interstitium. Okay, this is about the tubule, inside the tubule. Okay, so we'll just give a value, certain values to this. Since because this fellow has given all his belongings to the interstitium, so this fellow will become poor. He'll only have water. So he'll become from 400 it was, but now suddenly it will always become 100, and then it will become 100, 200, 200, then 60. Okay, like that. That much it will decrease till here, till the second part of the distal tubule. Okay, Now, the values I have given you, the values of osmolarity, and I have given you that. So you have understood about the dilution of the lumen fluid, and you have understood about the concentration of the medullary institution. Now, let's put the last part of this interstitium from that time we are focusing, right? I will just write the name again. I think you have understood this now. I will just write the name for you guys now. Is it self-explainable or not? Tell me, my friends. Yes. Counter current means what I have told you, because it comes like this and it goes like this. That's why I given a name as counter current. But why multiplier? What does that mean? Multiplier name is only given for the interstitium and the loop of Henle. Why? Because it is multiplying the osmolarity, right? Did you get this? Did you get this? Yes, you have gotten this, right? So now let's go back to our notes, right? Let's go back to our notes. Till now, what have we finished? Yes. Till now, what have we finished in the concentration? Focus over here. Till now, what have we finished? Yes, we have finished the medullary gradient, in which we have finished the development. Then I will finish the maintenance, and then we'll just go to ADH, and the concentration will be over. Apart from that, the dilution part is easy. There's nothing much there. I'm going very slow today. Sorry, guys.
SADAT,
Okay.
there's a doubt for
Yeah.
you. You said that both loop of Henle and interstitium reach 1200. I think you have written something different down there, so they got a doubt. Can you once display the previous pic you drew? अभी उतारे नहीं gradients वो.
Random उतारो ना मैं. यहाँ पे. This was the last diagram I have drawn.
Someone is asking, you told 1200.
Yeah.
Something.
So this was 1200, and the loop of Henle was becoming 1200, right? Yeah. There's nothing wrong, my friend. But I just wanted to, yeah, you have understood the multiplier. Okay. So now some people will be asking, the most important part of that is, see, the blood which comes to the kidney. Okay, kidney. This part. Okay. Yes. I think, I just want a suggestion from Nusrat and Arbaz. I think this session is going, I think I have to end it in 10 minutes, but I have still more to cover. What is your opinion on that?
Go on. It's okay. I think from my side.
recycling बोल के खत्म कर दो. ADH mechanism, urea recycling बोल दो, बस बाकी का पढ़ ले सकते.
Yeah.